It's my distinct pleasure to introduce my great friend, Dr. Juan Granada. Dr. Juan Granada is a fellow countryman from Colombia. He's originally from Medellin. And we didn't work together in that institution in Medellin, but we were just chatting that we crossed paths back there. That's where I kind of started doing some of EP and actually did my first publication in RVOT tachycardia. Anyways, Dr. Granada is the president and chief executive officer at the Cardiovascular Research Foundation in New York since 2017. He's also an associate professor of medicine at the Division of Cardiology at Columbia University College of Physicians and Surgeons. He leads a multidisciplinary research group which aims to accelerate the validation process of promising emerging technologies in areas such as cardiac imaging, innovative cardiac devices, and tissue engineering. He's also the co-director of the Transcatheter Therapeutic, or the TCT, Annual Scientific Symposium, which is the largest and most prominent interventional meeting in the world. He's been doing this since 2013. Now, Dr. Granada, as I mentioned, is originally from Colombia. He obtained his MD at the Institute of Health Sciences in Medellin. And then he moved, actually he started as an electrophysiologist. Unfortunately, he strayed away from that exciting career of EP and went into interventional cardiology. But he moved to Marshfield in Wisconsin, the University of Wisconsin. And actually, one of his mentors was another great friend of mine, Dr. Humberto Villayet. And of note, Dr. Granada has always been a forward thinker. Back then, one of his first publications in the American Journal of Medicine, I think it was in 2002, with Dr. Villayet, was actually a population study of atrial fibrillation and atrial flutter of over 5,000 patients from the Marshfield Epidemiology database, in which they were already predicting that the AFib and AFlutter were bad. There was about a 2.5-fold increase in mortality and in heart failure. And they're always saying that, early intervention and early diagnosis was important. Go figure, that's what we're trying to do now with all our early intervention in atrial fibrillation. He's a leading investigator in the field of translational sciences. He's got over 150 publications in PubMed, many book chapters. He has 24 patents. He has several awards. Now, he got the Young Investigator Award at the American College of Cardiology in 2000, and again in 2008. So he's able to stay young for 8 years in the time. He also got the James C. Willerson Vulnerable Plaque Young Investigator Award for basic research. And he also had the Outstanding Young Persons of the World Award. And he, as I mentioned, has more than 20 applications for patents in medical device technology. He's been in the forefront of first in-man and in-human technology with some stents, with actually the Sephia transmitral valve that I think he's going to talk to us about this. He's been in the steering committees and investigator of the Illuminate, Sabre. He's also even designed some technology for pulmonary vein isolation. So in brief, he is really a Renaissance man and also one of my personal good friends. So Juan, thank you very much for joining us today. And it's your turn to take it over.
Right, Carlos, first of all, thank you for the amazing introduction. I'm really humbled to be here and, share this hour with you guys. Hopefully we're going to be able to see each other in person and restart some level of normal activities. The digital media, can sometimes actually be boring. So one of the things that I am going to do during this talk is to mix a little bit the future, the present, the controversies, the innovation, a little bit of business aspects of healthcare. So I provide a perspective of what I believe is going to be a bright future in this field. I really think we are at the beginning of another revolution after balloon angioplasty, stent angioplasty, and TAVR. And I really think that all this innovation in the structural space is going to provide a lot of opportunities to the new centers to develop new centers of excellence and work closely with the surgeons to achieve better patient care. So the only conflict that I have for this talk is I'm a co-founder and co-inventor of the Sephia Valve technologies that is now owned by Abbott Vascular. One of the things, when you talk about innovation in the structural heart disease space, is that we all have to realize the unmet clinical needs today in healthcare are evolving. And we all, as academicians, actually have been raised in this environment that long-term outcomes are the most important thing. Maintain or improve health or actually quality of life, or prolonged life expectancy. And any time that actually we have a trial, or every time we actually were judging a clinical study, we talk about p-values, differences in mortality, and that is actually has been the focus of technology development for quite some time. But one of the things that actually we have to realize is that there are certain things, actually different variables, that make a profound impact in healthcare costs. And one of the things that actually make a big impact on healthcare cost is complication of device implants or any type of surgical procedures. At least in the US, you're talking about almost $13 billion a year invested in managing complications from procedures. The second actually biggest expenditure, and it's actually really, really, really big, is the management of chronic conditions, and actually account for most spending in healthcare. So one of the things that is happening right now on innovation is we should not really forget that long-term outcomes, life expectancy, quality of life is extremely important. But now more than ever, short-term outcomes are extremely important. Relief from acute illness, decreased procedural complications, improvement of actually short-term mortality or symptom relief benefit are also equally important, if not actually as important as long-term outcomes. So while the ultimate goal of medical innovation is to restore health and increase longevity in an aging population, the relief of symptoms and complications related to chronic conditions may have really a profound impact in the healthcare system. Why am I saying this? Because if we go back to the history of innovation in the structural space, the surgical field stayed on inertia for quite some time, and that actually allowed the disruption of the field by other technologies. If you go back and actually look at what happened with the aortic valve field, for the ones that actually did balloon valvuloplasty, several decades ago, we essentially used to stratify the patients as good surgical candidates and not good surgical candidates. If you were not really a good surgical candidate, pretty much you would die, from aortic stenosis. So if you look in the surgical AVR field, innovation was iterative, pretty much essentially little improvements over time, mainly actually related to valve design, durability of the leaflets, thrombogenicity, and perhaps the biggest advance was the refinement of the procedure with the introduction of minimally invasive aortic valve surgery. But the aortic valve surgical field has stayed actually very stagnant over time. And that actually provided opportunities for innovation. While the surgical field was pretty much focused on long-term results and the durability of the leaflets and improvement of the surgical techniques, there were significant unmet needs and opportunities that actually allowed TAVR to start. Number one, limited options for the aortic stenosis patient in prohibited risk population. And the second thing, the potential to improve peri-procedural outcomes. And this is important because the second opportunity is the one that opened the doors for essentially going into lower risk populations. The history of innovation in TAVR is really amazing, especially because the timelines. I have to tell you, in innovation, 10 years is not really a lot of time. The first balloon expanding TAVR essentially was published in 2002. The first approval of the Edwards Sapien valve, the first balloon expandable valve, actually happened 8 years later. That was actually really amazing, the amount of work that was done to essentially get the first technology approved. Intermediate risk patients actually were, the use for intermediate risk patients was approved in 2016. And by 2019, we pretty much have an expansion, reversal expansion for the use of TAVR even in lower risk patients. This is a publication that I think is going to be very important for the future of TAVR, and this is the first report of the 2 years data in low risk population. This is actually important because this is really the first glimpse to the future in terms of what this technology could potentially do in patients that actually are also good candidates for cardiac surgery. The summary is that at 2 years, death and stroke that favored TAVR at 1 year were not statistically significant in 2 years, but still you actually see a numerical difference favoring TAVR. Valve thrombosis, though, increased after TAVR 2.6% versus surgery 0.7%, and this is extremely important, finding in this population. Disease-specific health status continued to be better after TAVR versus surgery, and echocardiographic findings, including hemodynamic valve deterioration and bioprosthetic valve failure, were similar. This is important because essentially we start to see the differences between the patient that has a lifespan that is shorter versus a patient that has a lifespan that is longer. And at the end of the day, it's not about which one is actually superior or better, but is what is the best approach for the patient population according to the demographics, risk factors, surgical risk, surgical skills, and so forth. So this is actually very interesting because right now, TAVR, I really think it's fair to say, is actually the present, and TAVR now is becoming now going into a plateau phase, or what we call an innovation and iterative phase. So we're going to talk more about the future, but actually few words about what I think is going to come, for TAVR in the future. Now, I think the biggest fight in terms of innovation and clinical trials is going to be now on long-term results, leaflet durability, thrombogenicity, and actually device characteristics in general. Further simplification of the technique to actually make the procedure simpler and actually safer, better vascular access and closure, the use of embolic protection devices or not, and actually valve design iterations, especially getting rid of paravalvular leaks, et cetera. So I think right now TAVR got to the point where surgery actually was at the very beginning, in which now the improvements are going to be small and not really as significant as they have been over the last 20 years. Mitral valve innovation is different, and people try to essentially equate the TAVR field with the mitral field, and we're talking about completely different fields. We also really take into consideration the type of clinical risk the patient has for a surgical procedure, but also aortic stenosis is somewhat a uniform disease. Here we're talking about different disease substrates that essentially come into a syndrome, which is actually called mitral regurgitation. You have actually not only one condition, but two conditions, and you can argue that DMR or primary MR has multiple conditions associated to these disease state as well. Also, surgery essentially had a very, very drastic actually curve of innovation, but then actually plateaued. And most of the targets for innovation were essentially the fight between repair versus replacement, diverse rings versus valves, mechanic versus biologic, and the introduction of valvular robotics. But something that happened on the mitral field that didn't happen early on the aortic field is the introduction of catheter-based edge-to-edge repair or MitraClip. That essentially allows expansion of indication to higher risk patients, and on my view, actually made our field more difficult because now we have to compare equivalence not only against surgical candidates, but also actually potential MitraClip candidates. But there are still unmet needs and opportunities. I mean, one of the big unmet needs is the treatment of FMR in high surgical risk patients because, as you know, surgery is somewhat actually controversial, and the MitraClip results are not really perfect. The patient that we call unclippable, the patient that has an anatomy that really is not really that good a patient candidate for MitraClip, and also the improvement of post-surgical clinical outcomes. This has really led to a massive investment in the structural heart space. And you can actually see here, this is a summarized slide of all the technologies right now that are under development. including repair and replacement technologies, most of them inspired by what the surgeons do in the OR. And you can really see that the amount of data collected with all these devices is just significant. It's just amazing that what is actually going on in this field. But I actually have friends, Carlos, and I have a very close friends that essentially asked me this question. They said, look, the surgeons do a phenomenal job. They know how to repair these valves. You know, they have great clinical outcomes. Why is innovation needed in the mitral space? And I really think this is a very important question. The reason is because there is a large unmet clinical need. And I really believe so. We actually are facing an aging population that is growing actually worldwide. The number of patients with mitral regurgitation is actually growing and will continue to grow over time. These high-risk population are frequently rejected from surgery and not well represented in clinical trials and in the literature. So it's not really fair to say that the great outcomes on high-volume centers are the same outcomes that we're going to get with these patients. And the poor surgical outcomes that essentially are associated to intervene these patients actually bring a significant high financial burden. So I really think there is an important population out there that could benefit from lesser invasive approaches and actually better outcomes with minimally invasive technologies. One of the things that actually we do know is MR severity in FMR and actually DMR impacts long-term survival. The worse it is, the worse outcomes actually patients have across the board. And one of the things is these patients have a very high mortality rate if they are actually left alone untreated. This is a paper that I really like a lot because essentially shows not only the technical trends, but also the natural history of disease in patients that actually were not operated and were essentially left alone. This paper included 1,100 patients with severe MR between 2000 and 2008. 24% were FMR, 21% DMR. As actually typically happens in big volume centers, patients with DMR most likely underwent surgery. Patients with FMR actually most likely went and were treated conservatively with medical therapy. Unoperated patients that were rejected had lower ejection fractions and actually higher STS scores compared to operated patients. What is interesting is if you actually look at prognosis of the patients that were not operated, you see that the survival essentially decreases and actually rehospitalization increases and mortality actually increases over time. And you can actually see that approximately at 5 years, approximately 50% of the patients essentially are dead and 90% have been rehospitalized again for heart failure. This brings a lot of cost, brings a lot of complications in actually patients that otherwise could improve with minimally invasive catheter-based techniques. This is actually a different analysis that was done by Greg Stone based on actually these findings, looking at the demographics of these patients, and approximately 36% of these patients, could have been treated with MitraClip, just as a reference. Another reason why is innovation needed in the mitral space is because the final goal of mitral valve intervention is essentially achieve good outcomes, essentially fix the mitral valve, potentially with fewer short-term perioperative complications. And actually, complications are expensive, as I showed before, and decreasing the number of complications can potentially improve the financial performance, if you will, of this type of procedure. In every single field, progression towards minimally invasive interventions impact clinical outcomes, quality of life, and overall healthcare cost. I'm bringing this paper because it's a very interesting paper. It's one of the few publications that essentially randomize patients to mitral valve replacement and repair in a properly randomized prospective clinical study. And I'm not going to talk about the outcomes here. I'm going to talk about here is about peri-procedural complications at 30 days. This is important because you're talking about the best centers, the best surgeons, high volume centers, actually highly selected patients. And you actually see that the percentage of complications that could, I'm saying could potentially be prevented by the use of actually some minimally invasive catheter-based techniques is important. It's actually close to actually 10%. talk about respiratory failure, talking about sepsis, you're talking about bleeding, potentially actually complications that could improve the financial efficiency of these procedures in high-risk patients. Another important thing is, I agree with my friend, you know, when you have a phenomenal surgeon that essentially does a lot of hundreds of repairs a year, the outcomes that actually get are very, very good. But the reality is, especially in underdeveloped countries, to have high volume mitral surgeons is really not that easy. And including the US, the volume is not really that high for most of the centers. So access to high level surgical care is variable. And broader treatment access and standardization of techniques is more easily achieved with the catheter-based approaches. It's easier to standardize a catheter-based procedure such as MitraClip that right now is fully standardized than essentially trying to standardize a surgical technique that is pretty much operator oriented based on the independent skills of a surgery. So where is innovation needed in the mitral space? And this is actually an important question because, again, on my view, there is a misconception that actually functional MR is an easier field to get into than DMR because DMR is already taken care of. And actually, again, there's the same fight in this field as it happened in the surgical field, repair versus replacement. Which one is actually better, easier, or low-hanging fruit for innovation? The reality is, if you talk to clinicians, if you talk to surgeons, there is always actually a trend towards repair. People actually, surgeons and physicians, they actually favor repair because it is actually perceived as a most elegant procedure, doesn't leave things behind, and essentially doesn't require the use in a lot of patients of long-term anticoagulation. So I chose this paper because this paper is one of the few that has really, you know, looked at the outcomes of repair versus replacement in a population that essentially is capturing a single center Cleveland Clinic, and they essentially adjusted by comorbid, you know, variables. And it's interesting to see that at first glance, yes, as is actually shown in some studies, repair was superior than replacement when it comes down to survival. But when you adjust by actually comorbid conditions, these differences actually disappear. One of the big conclusions of this paper is that it is reasonable to perform valve repair in elderly patients with complex DMR because it can eliminate the need of anticoagulation and risk of prosthesis-related complications. However, when valve pathology is so complex that repair is infeasible, this study demonstrates that valve replacement doesn't diminish long-term outcomes. And when you actually see publications that really adjust, you know, by comorbid conditions, pretty much actually this superiority of repair starts to decrease. If you look at the paper and actually go deeper, you see these populations are different. The patients that actually are selected for repair are typically younger, and the patients that actually are going to replacement are typically patients that are not good candidates for actually repair. So there is actually intrinsic bias in the trials and in selection of these patients that is influenced by patients' demographics, valve anatomy, comorbid conditions, and the most important thing is surgical expertise. So at least from my point of view, if you have a great surgeon and you can actually select repair or replacement in terms of outcomes, they actually are pretty comparable. Now, what about FMR versus DMR? And I really think this one is a little bit more controversial because the surgical data on FMR is a little bit, you know, inconclusive. And in comparison to actually DMR, in which patients are younger and the surgeons do a phenomenal job repairing the valve. This is another randomized trial published in a New England Journal that essentially compared head-to-head mitral valve repair versus replacement in FMR patients, a total of 251 patients, both groups actually having similar numbers, and at 12 months, no differences in left ventricular end systolic volumes, all-cause mortality, or composite cardiac endpoint. But there was a significant difference, as actually expected and is being seen in some of these technologies, in recurrence of mitral regurgitations. These differences were maintained up to 2 years. Now, the problem is when you actually look at the surgical literature, you actually find a lot of, you know, different actually papers that essentially, you know, show different things, typically actually favoring repair. But again, when you look at studies, again, not really that big, 250 patients, you really see that when you adjust by comorbid conditions, essentially the differences are not really that significant. Why am I saying this? Because in reality, is at the end of the day, is about skills and is about results. This is a very famous graph that is shown on actually the stocks that essentially show that as time goes by, recurrence of mitral regurgitation or the repair efficacy starts to decline over time. And it can start between 10 to 20% of moderate MR. And over time, the incidence of mitral regurgitation starts to essentially increase over time. So at the end of the day, is a good repair is actually excellent. A bad repair is not really good. And actually a replacement is better than a mediocre repair. And that also applies to catheter-based techniques. We know that there is linear correlation as it happened in TAVR with post-operative residual MR and long-term outcomes. And this is important for catheter-based techniques because we're giving a pass to catheter-based techniques to essentially end up with more regurgitation that we would like to, and it's not really fair because we need to really achieve the outcomes that essentially the surgeons achieve with surgical-based techniques as well. So where do I see the field going in terms of replacement versus repair? In the way that I see it, transcatheter repair, would be specifically indicated in patients in which anatomical abnormalities are so specific that could be repaired, avoiding the surgical trauma. This is one of the examples of one of the technologies that are right now under investigation, NeoCord. This is a patient with a posterior leaflet prolapse, as you can see, with significant MR, and you see the significant amount of prolapse. And transapically, you can go with a catheter, grab the leaflet, and attach artificial cords to the apex and completely repair this valve. This is really minimal invasive. You don't need to mess with the valve, and you can really fix this specific structural problem with a catheter-based technique. Right now, there are companies doing the same thing, but using the transeptal approach. Another example, when you, for example, have specific conditions like in this video, regurgitation of the posterior leaflet, and with a specific device, you can put an enhancer that essentially pushes the posterior leaflet up and improve the coaptation line in this particular patient. These are technologies now are approaching into first-in-human clinical studies, and with a very simple clip delivery, you could potentially fix a specific anatomical problem. This is a patient in a technology that is approaching first-in-human study, and we hope to actually do it soon with a half-moon device that is the same thing. It's a posterior leaflet enhancer, and as you can actually see here, you produce augmentation or produce a space augmentation to improve coaptation of the leaflets and decrease regurgitation in patients with a specific structural abnormality. This is where I really see catheter-based repair can really have a significant impact in actually patient population with a specific structural defects. There is actually a population that continues to be growing and continues to be identified is what we call the unclippable patient. We're now actually selecting patients for mitral clip procedures, but we started to find a population that the surgeon doesn't want to touch, the interventionalist doesn't want to touch because the anatomical abnormalities. And one of these very common abnormalities is mitral annular calcification, very common in the elderly. And I really think for this specific populations, replacement could be a better option and superior than repair in this particular patient subset. I think because they're easier to use and they provide a more comprehensive solution to mitral regurgitation, replacement at the present time, is essentially capturing the imagination of interventionalists and people in general in this field, mainly because everybody is inspired about the story of TAVR and how fast we were able to move. And honestly, to be able to replace a full valve going transeptally is something that is really amazing. The value proposition is actually there. It's easy to implant, quotation mark. It doesn't really matter what the etiology is, if it's primary or secondary. You abolish MR with a valve. You decrease actually MR with catheter-based techniques with the hope of potentially abolish MR, but it doesn't happen in all the patients. And you actually hope that there is less recurrence of MR with replacement rather than essentially repair. The biggest question and the biggest challenge as it happened in TAVR is how do we move from a highly controlled environment in which the surgeons have done a phenomenal job essentially fixing the valve in place into delivering a catheter with without the need of any sutures or support. So what are the technical and clinical challenges of this field that actually promises to be extremely disruptive? The first thing is, as I said, we're dealing with different disease stages and we're different disease etiologies with actually different architecture of the heart. And it's not really easy to really develop a technique that is able to cover all the potential variations that happen in primary versus secondary MR. As of today, and I want to make it very clear, surgery is the standard of care in patients with mitral regurgitation that are thought to be good surgical candidates, period. Very different than actually TAVR. And I would actually say that once it gets into the high risk, prohibitive risk, actually section, this is where MitraClip starts to actually play a role. And MitraClip is trying to expand into the intermediate risk population, actually having some challenges from the clinical and technical point of view. And right now, TMVR starts as actually TAVR started in the prohibitive risk population. So right now it's an experimental, device, an experimental approach that is essentially teaching very important lessons to the field and to the interventionalists at large. One big challenge that we have is that MitraClip essentially came into the picture very early into the innovation process in the mitral field. We have a technology that actually has data on DMR and FMR. We have a technology that has shown to decrease hospitalization and mortality in very sick patients with heart failure. And right now, when you introduce a new innovative approach, there has to be a screening method that essentially rules out the patient for MitraClip and actually surgery before you even think about essentially doing a patient like this. And I really think this is going to make the validation process and the introduction of new technologies more challenging in the future. Another important thing is at the beginning of this field, when we started, working on innovation on the mitral, replacement field, everybody came up with their own conceptual design. So we have designs that are actually shaped. We have some that are actually soft, some actually hard, some actually grab underneath the annulus, some actually grab above. The reality is when you start screening patients with mitral regurgitation, you come to realize that the anatomy and the variability is really significant. Very different than TAVR, in which you may see variations in size and actually calcium deposition. In mitral, there are multiple anatomical abnormalities that makes the universal development of a single design very, very challenging. So very likely some anatomies are going to benefit from some designs, and actually other patients may benefit from other technologies more than actually others. Another thing that happened very early, and it was very challenging and a little bit of a stressful part, was, can we really keep these valves in place? You see here an experimental implantation of a valve where essentially the valve is expelled completely from the ventricle by the porcine myocardium, because the retention was not really good enough. This is actually one of the first in human case that were done with an experimental device, and you see that the valve embolized, from the position. Fortunately, actually, engineers did a phenomenal job with the multiple iterations of anchoring, and so far, with all the implants that we have seen, valve dislodgement has not really been an issue. And this was actually a big, quantum leap in the technological development, because one of the biggest concerns that it happened in TAVR is, are we going to be able to keep this valve in place? The answer is, we know right now, yes, we can actually achieve that. The biggest issue that we're finding right now is on patient selection. Mainly two things: LVOT obstruction and actually the presence of MAC. LVOT obstruction continues to be the Achilles heel of this technology, mainly because a lot of these valves are actually very tall and go very deep into the ventricle, potentially obstructing the LVOT. So there is a very high rejection rate. And in my opinion, There has to be a redesign of these technologies to be able to be highly applicable in the future. The problem is, due to the wide variety of designs, this is not really something that we can predict with actually simple imaging algorithms, and all these imaging algorithms right now are customized to the valve design and so forth. What is the clinical data that we have with these systems? Because the size of these devices, and as you can imagine, you're talking about now big systems or big valves. The field started with transapical systems going directly, minimally invasive through the apex. And these are tons of companies actually doing a lot of work, but these are the 4 companies that at the present time are considered to be the front runners in the transapical space. As you can actually see, all devices are above 30 French. Actually, some have recapturability features, and some actually have a lot of sizes to be able to really treat a lot of patients. This is one of the most advanced systems in terms of the clinical program. This is Tendyne, in which the device is inserted through the apex. Once the atrial flange is open, the valve is actually pulled and is attached to the apex with a tether, as you can actually see here. Is actually pretty simple to do, based on actually echo guidance, a procedure that is not really that complicated to do, but it still is minimal invasive, but it still is surgical. This is the publication of the first 100 patients, even though they have already several hundred patients enrolled. You see the implant success is very high, 97%, with very low apical axis complications, a mortality of 30 days of 6%, which, remember, these are patients that are rejected for every single procedure. They're poor surgical candidates and not really good candidates for anything else. But you see the mortality and the complexity of these patients, in which mortality at 1 year, is still 26%. So this is what I call a technical biological proof of principle that essentially shows the first device performance in this type of patients. The other system that is right now also going into advanced clinical studies is the Intrepid system by Medtronic. As you can actually see here, it doesn't need actually a tether, and is a device that anchors by essentially mechanical force. It's actually a soft device that self-anchors in the mitral annulus. You see most of the patients that have been enrolled are secondary MR. You see the low number of MAC patients included, and most of the patients have left ventricular dysfunction, but a very, very small number of patients, ejection fractions below 25%. Again, an advantage of these systems is complete abolition of MR, which is really what makes these type of technologies exciting. And there is a significant actual improvement in quality of life and functional capacity in these patients. But again, you actually see they studied with 95 patients in this first report. You see the 12-month actually already had 58 patients followed. The rest of the patients dead or lost at follow-up. So this is a very sick population, and this is a biological technical proof of principle. Both studies right now, both technologies have been are undergoing randomized controlled studies. The Summit study is testing actually Tendyne, and the Apollo actually the Intrepid system. Tendyne is randomizing against, actually its brother by the company against MitraClip, and the Apollo right now that essentially was randomized against surgery. There are discussions right now of modifications of the study to become actually single arm. But everybody wants to see the transition to the real deal, transeptal delivery, transeptal delivery of these technologies. And I have to tell you that has not really been as easy as previously thought. Imagine you have to get a 35, 34 French device and pack it into a 27 French device. It's really a lot of force to be packed into a small system. And the amount of flexibility, torsion, to be able to navigate a device of that size into the left atrium and left ventricle is not really easy to do. There is also concerns about septal disruption and septal trauma. And that's why the companies really want to go as low as possible in terms of French size. So the transition, even though we're already there with some systems, as I'm going to show now, has not really moved as fast as everybody actually wanted. In a way to modify and actually decrease the French size, companies like, for example, Edwards decoupled the valve from the delivery system. And you see here This is actually the M3 system in which an anchor is actually placed first. And then once the anchor is placed first around the survival apparatus, then a modified Edwards valve comes second. And in that way, you can really decrease the profile of the system. This is what actually I call a two-step approach. And there are at least 3 companies working this type of approach. The first 35 patients were actually published recently. And what is interesting is that you really see an improvement in the 30-day clinical outcomes compared to the transapical approach, in which you get bleedings and you get actually apical complications. And again, with a significant abolition of mitral regurgitation. So this is one of the technologies right now being under investigation. This is the Evoke system that is very similar to the transapical system by Edwards, as you can see here, fully transeptal. The idea is to open the device and open these fingers that are essentially are projected underneath the leaflets, as you can actually see here. Once you grab the leaflets, you deploy the atrial component and anchor the device in a supraannular position, as you can actually see here. There's a beautiful echo representation down here that shows the mechanism of anchoring. And right after deployment, the number of patients, again, less than 30 patients, published so far, with actually similar results than the M3 that I showed. This is again the variation of the Intrepid system by Medtronic, but here the deployment happens in the atrium first, as you can actually see here. Once the atrial flange is deployed, then the ventricular component is deployed, as you can actually see here, and you see the final result, the valve being essentially left in place by mechanical compression. This is a system that essentially was studied and invented in our center. It's called the Sephia Valve, and we recently published the first 3 patients done in Canada, a total of 6 patients, 7 patients done worldwide, with a system that is a surgical-like device, very, very low profile, is fully transeptal with a low-profile frame structure, so there's minimal interference with the LVOT, and has optimized hemodynamics because the valve is being designed to be a surgical-like technology. You see here the first implant that we did in humans, very simple system. You see the amount of MAC significant in this patient. You position the catheter underneath the annulus, then you deploy the ventricular component to anchor the valve underneath the mitral valve, and then you put traction to the catheter to bring the ventricular component back until you essentially anchor the valve and deploy the atrial component, leaving the valve behind, a very, very low profile valve, as you can actually see here. You see the final result in this particular patient. One thing that is really amazing after mitral intervention is just to see how the patients essentially do. You see 24 hours after the procedure and 2 years, the patient essentially really, recovered in a very, very simple way. The patient was, sent home after 4 days of intervention just because we wanted to monitor the patient, but the morbidity is drastically decreased by the use of catheter-based techniques. So I think that we all agree the final goal of this field is really go transeptal, catheter-based, transvenous, but significant improvements need to happen in order to make this field viable. First, these designs need to adapt to all the variations that actually we see in human anatomy. They need to perform in real-world anatomy, including MAC patients, need to go into smaller catheters to decrease tisular trauma, and there has to be a significant evolution in imaging, planning, guidance, and actually also training. So this is actually a very exciting field, but it's still a lot of lessons to be learned. Just to finalize this talk, I want to say something about this field. This is not about saying we're going to replace surgery, because that is not going to be the case. The question is, as I said before, is what is the best indication? What is the best patient profile that can really be helped with the use of this technology? And one of the things is we're learning a lot of lessons with this catheter technology, but I have to tell you that compared to the historical data we have from surgery, we're far, far from actually being there. And now there's been a lot of discussion about what the outcomes of clinical trials and the outcomes that actually need to be expected with catheter-based techniques. And I really think the standards have to be the same as surgery. Minimize recurrence of MR, minimize thromboembolism, take actually arrhythmias and the role of anticoagulation as a potential important component of clinical outcomes in these patients. And one important thing that is started to really get into the clinical arena is try to treat tricuspid regurgitation earlier rather than later. Because one of the things that actually was learned is the progression of tricuspid regurgitation and leaving this behind is something that actually do not really favor the patients. So the TAVR development timelines, as I said before, happen very quickly. And right now in 2020, we have general patient adoption according to the race population and actually skills of the centers. Mitral is still at the early stages of this pathway, and I really think it's going to take some time before we learn of these lessons and we apply this into a generalized population. Finally, tricuspid regurgitation is now identified as a potential target for innovation as well. And one thing that is interesting is, I don't know if you remember the graph that I show about mitral regurgitation progression over time, getting to around 20%, 10, 20 years, because all the great surgical tool that we have used in the past. The reason why we see more tricuspid regurgitation right now is because tricuspid regurgitation historically has not really been aggressively addressed. And there is now a sense of awareness amongst the surgeons and interventional community that maybe we need to change the way we see, these patients and be a little bit more proactive, with interventional techniques, surgery or interventional techniques to treat patients and actually get, better long-term outcomes. The tricuspid actually field is a completely different animal with a lot of techniques, innovation, and as hot as the mitral field, but I don't have time to expand into it. But it's another amazing field that is actually really taking off in this particular area of innovation. So in conclusions, catheter-based valve intervention is today one of the most exciting and potentially promising fields in interventional catheter-based innovation. Unlike TAVR, specific device attributes will influence patterns of technology use, clinical outcomes, and physician adoption. The successful development of this field depends on a proper, thoughtful, and stepwise validation approach. And this is extremely important, including a clear definition of the target disease and population, refinement of imaging and co-registration tools, and all the lessons that we're learning right now from early feasibility studies, are really leading technological improvements and trial design strategies that I am sure are going to help the further development of this field. So I'm going to stop here. Thank you again for your attention, for the invitation, and I think that we're open to discuss this presentation.
Thanks, Juan. That was a fantastic presentation. I'm trying to see if there's any questions here in the chat until we get some. So let me ask you something. So you did make a point about the differences in mitral valve regurgitation and how difficult it is to predict which type of repair or valve you need. So how do we improve on that? So more like precision medicine. You think we're going to go into AI and machine learning to try to predict which is the best procedure?
Carlos, we're actually, you're absolutely right. We're actually going in that direction. If you see, for example, the direction that edge-to-edge repair is going, there is a lot of work right now in trying to identify, the patient that is going to improve on a population-based basis, because it's not just about putting a clip. It's about, demographics, risk factors, myocardial performance, and so forth, but also in how to really get imaging and essentially analyze the imaging findings to essentially tell us where to put the clip and which patient can potentially improve, but all the flow dynamics that you see in a computer-based model. So I really think that we're going that direction to better utilize this technology.
Now, the other thing that you did show, and you have that nice slide that kind of summarizes the important things. And do you think at some point, we should have these teams of EP, interventional, and surgery? Because, I'm seeing that the next few years, some of this procedure is going to have, you're going to deploy a Watchman, you're going to do an AF ablation, and at the same time, we're the best guys for transeptals, so we can help you deploy the thing and, get that done. And, when you're coming out from the LA, you put another clip or something to the tricuspid, which is also going to be essential. So you think that in 5 years, the structural heart team will need this kind of a hybrid group?
Carlos, listen, I agree, and it is happening right now because even within the field, there is a significant degree of specialization, right? You're talking about, for example, imaging people that right now are dedicated to structural interventional procedures, all right? You're talking about people that are doing more LAA than other people that are actually doing specifically more mitral clip. I mean, it's difficult to be specialized, especially when the volume is not really there. But I really think that a multidisciplinary team that essentially work together, that cross-train together, surgeons, interventionalists, and imaging people is going to be required. And the amount of training that will be required in the future to be able to train everybody is really significant. And I want to make an emphasis again, it's not about surgeons versus interventionalists. I have to tell you that right now, our surgical fellows are as skilled as interventional fellows, and they do as many procedures as the interventional fellows. This is about actually a skill-based approach and actually team-based approach, because it is when you have a vascular complication that you're actually going to tell your surgeon, now you come in and help me. So I really think this is extremely important to work as a team and learn actually together about the decision-making process.
Yeah, now the other issue is, so how do we kind of decide what are the centers that are going to do this, and what is the minimal volume required to actually have this, seal of approval that you're actually a good center to do this?
I'm not going to answer that question because that question is really, really, number one, is relevant. Number two, requires consensus. And number three is it's got a lot of political ramifications. But one thing that is extremely important, Carlos, what you're saying, is that the centers work really to keep their volumes and actually skills up. For example, you have to really work with the heart failure teams to be able to identify those patients that could potentially benefit. You really need to actually work with your referral physicians to actually create awareness of this type of procedure that can benefit some specific subsets. And you really need to keep your volume, because you cannot really do one mitral clip a month and really maintain the level of skills and outcomes that actually this procedure requires.
Now, the other obviously, pressing issue is cost. And, how do we make these procedures a little bit more approachable? Is that something that's coming in the near future? Is this only going to be depending on the fact that, well, we'll do 30 of these a year or 50, and then prices are going to come down? What is the real impact from the health resource utilization so that we can kind of promote these kind of teams and procedures?
So it is actually really really sad, because we go back again to the stent story. When stents were introduced, I mean, you remember, a Palma shot stent, cost $3,000, $4,000 for a piece of metal, and right now, because the amount of money invested in the validation of this technology, the prices are very steep. I'm saying it's really sad because in underdeveloped countries in which the amount of surgical, teams, and expertise and actually intensive care unit care are not as specialized as centers in North America, for example, they could benefit from standardizing and using devices like TAVR, in which the procedure is simpler, potentially. I mean, the complication rates are lower, and you could potentially treat more patients with less qualified need of skills and post-procedural care. But right now, that is one of the biggest challenges and barriers, because the cost is prohibitive. And if you see the penetration of TAVR and mitral clip in Latin America, I'm putting this example because it's a closer example to us, is very, very low.
Now, the other thing that also is important in this kind of pathology, both TAVR and mitral regurgitation, is the association during and even before these procedures that a lot of these patients have silent cerebral ischemia. and this leads to cognitive decline. Now, what do you predict the future of this? Are we going to be using some of these protective devices, or are we going to be doing a combination of low dose antiplatelet with low dose NOAC? How do we tear down? Are we going to be able to have an impact on cognitive decline with these devices that will also have some significant social implications? Where do you see this field go in that sense?
Carlos, the use of cerebral protection, even in TAVR, is controversial because really the data doesn't really support, in general, the clear benefit. I have to tell you that big TAVR centers, we use protection, brain protection, in almost every single case, and it's actually more based on what we see, but based on the MRI results and cognitive tests that actually people do in patients. And it's amazing to see the amount of cases that you see a lot of stuff in the baskets, and you say, thanks God we used it. On the mitral field, may be actually be more relevant because it's a relatively actually low flow area. You're going to be messing with the left atrium, going into the ventricle. And I really think that, unfortunately, as it happened in the TAVR field, is going to be more of a safety mechanism rather than, or insurance actually, more than, evidence-based medicine, because it's very difficult to essentially prove the efficacy of this technology. We're talking about, thousands of patients to actually show a decrease in major stroke rates.
Well, Juan, thank you very much. Hope that we can join you in Miami for TCT in person this year. And looking forward to seeing you and the family sometime soon. Thanks again. This was a fantastic review, and hopefully we can bring you up to Calgary.
I hope we can see each other soon, actually, for sure. And thank you again for attending this